Welcome, everyone. My name is Dipali Kumar. I'm a transplant infectious disease specialist at the University Health Network in Toronto. And what we've done is divided the webinar into 3 or 4 sections. The first section will deal with presentation, treatment, and prevention of COVID-19. And I will introduce all the speakers. We have a number of speakers that will be going through this. Dr. Erica Lees is a transplant pulmonologist at the University of Washington. She will be followed by Dr. Ajit Lemay, who is a transplant infectious disease specialist at the University of Washington as well. We'll then have Attilio Iacovoni of the Heart Transplantation Unit in Bergamo, Italy, followed by Paolo Grossi, Transplant ID at the University of Insubria in Italy. And finally, we'll have Marion Michaels, who is a pediatric transplant infectious disease at the Children's Hospital of Pittsburgh, who will be discussing prevention, and then Lara Danziger-Isikoff, who is pediatric transplant ID at Cincinnati Children's Hospital. After everyone has done their presentations, we'll be doing a Q&A. And depending on the amount of time we have. So I will ask Dr. Lees to go ahead.
Great, thank you. And thank you for having me here to talk with you all today. You can move forward the slide. As was mentioned, I'm at the University of Washington in Seattle. Next slide, please. So I'll be talking about the background and presentation of this viral pneumonia illness. And so, as I'm sure most everybody knows, that there was a cluster of pneumonia cases that occurred in Wuhan, China in early December 2019. And it was ultimately identified and termed as a novel coronavirus infection, or 2019 nCoV. After more research was done, it was found to be an enveloped RNA beta coronavirus that was phylogenetically similar to SARS-CoV, which is a severe acute respiratory syndrome coronavirus, and so it was thus renamed as SARS-CoV-2. To be clear, COVID-19, which stands for Coronavirus Disease 2019, is the disease that is caused by the virus SARS-CoV-2. The infection spread quickly, and on March 11th, 2020, it was designated as a pandemic by the WHO. You can see here I included a map of the world that really there's no area that has not been touched by this virus. And the numbers below I added actually on Friday, and I have updated numbers. This also comes from the WHO. Now, since Friday, there are now 332,000 confirmed cases of coronavirus, of COVID-19, more than 14,000 confirmed deaths, and 190 countries, areas, or territories that are currently affected. Next slide, please. So we have a couple of reports that are telling us about the presentation of COVID-19. The initial report came out of the Wuhan, China group and was published in JAMA. And they reported the most common symptoms being fever in 99%. You can see the cutout from their presentation or for them paper right there, and dry cough in almost 2/3. About a third of patients had dyspnea. I do want to point out that those patients, the reports on these patients were from hospitalized patients, as is the second one that I'll review. So we don't have as much information about patients who may have more mild disease and what are their most common presenting symptoms. So the second report was published in New England Journal. And it was a larger report from China. Most of the patients were still the patients coming from Wuhan, but it also included other patients in China. They reported fever at presentation of 44%, but again, this was focused on patients who were hospitalized. Nearly 90% of the patients ultimately developed fever during their hospitalization. They saw a cough that was somewhat similar, about 68%, although they did see about a third of patients had a productive cough, and they saw dyspnea in about 20%. Comorbidities have definitely been reported as being higher likelihood of developing COVID-19. These two papers ranged anywhere from 23 to 46%. And using the paper in New England Journal and then another paper that was published in the Annals of Internal Medicine, it appears that the incubation period, again, by the data that we have, appears to be 4 to 5 days, but can be up to 14 days. And as we know, patients can be completely asymptomatic as well.
Ajit, we're ready for you.
Can you hear me?
We sure can. Go ahead.
Okay, great. Could we go to the next slide, please? All right. Thank you for the opportunity to participate. I think there's a lot of unknowns about how SARS-CoV-2 will intersect and impact with organ transplantation. I think there's a reasonable expectation based on analogy with other viruses in this setting that our organ transplant patients with their concomitant immunosuppression might be at increased risk potentially for acquiring the virus, specifically through either behavioral or biological features such as those that are listed here. And I think there's a lot of concern that there may be a higher likelihood of progressing from infection to more severe disease, perhaps as a result of underlying comorbid conditions as well as the impact of immune suppression. However, I will note that at least based on limited data with related coronaviruses, there wasn't necessarily an increased morbidity or mortality above and beyond that could be attributable to underlying comorbidities. And unfortunately, to date, the published data specifically on organ transplant patients with COVID is very, very limited. So I'm going to share with you in the next slide very preliminary data with our first 5 cases. Next slide, please. So I want to highlight a couple of important caveats as you look at these data, which literally could have been updated in the last few minutes since I've heard about a couple of additional cases. You'll notice that all of these cases are patients who are many years, more than 10 years, in some cases up to 20 plus years after transplant, and as a result, were on low-dose maintenance immunosuppression. Number 2, when you look at these data, please keep in mind that at the University of Washington, with one of the first available on-site real-time testing laboratories, we were able to develop specific testing algorithms that called for testing all immunosuppressed patients with any signs or symptoms that could be compatible with COVID. And so that testing bias may also impact the cases that have been diagnosed to date. But as you can see, we've encountered organ transplants of all types, patients who had significant underlying comorbidities that have previously been described to be associated with an increased risk of morbidity and mortality. The symptoms that you'll see for these 5 cases are quite similar to those that have been described in a general population, not necessarily immunosuppressed. And one thing we've been surprised with is just the range of clinical presentations, from those mimicking a standard upper respiratory virus infection to one that was suggestive of viral pneumonia. And the actual clinical care that was undertaken for these patients was in the inpatient setting for 3 of the 5, but 2 of the 5 had relatively mild symptoms and were managed expectantly in the outpatient setting. The treatments that were undertaken in the majority of patients was simply supportive care without specific changes to immunosuppression, and only one of the 5 patients, the patient with most severe symptoms leading to acute kidney injury, was hydroxychloroquine administered along with discontinuation of baseline MMF and the addition of prednisone. So far, with very, very short outcome, I want to emphasize all of our patients are alive at now approximately a week or greater into their clinical course. And so it raises at least the possibility that in patients who are very far out from transplant on low-dose immunosuppression, that perhaps the impact will be reflective of their underlying comorbidities rather than necessarily an attributable impact of immunosuppression. Next slide, please.
Okay, fantastic. First of all, thanks for your consideration. As you know, here in Bergamo, we had and we still have an explosion of COVID-19 patients. In addition, because we are a transplant hospital, we had also cases of COVID-19 transplant patients. And in total, we have observed 14 patients, but we present only the ones with the longer follow-up, 6 patients. Among them, we lost 2 patients. 2 patients are still in hospital, one stable, another unstable, and we have 2 outpatients. Next slide, please. Okay, let's start with the beauty. The first patient is a male, 15 years old, 4 months post-transplantations. He was on mycophenolate, cyclosporin, and 50 milligrams of steroids. He started to complain of fever, dry cough, but not dyspnea. And after 3 days, we decided to test him and was positive. At this time, the lab tests were normal. We just observed a slight increase of CPR. And the oxygen saturation was perfectly normal with no respiratory distress. So our strategy in this case was to stop mycophenolate and follow him by phone. And now, after 14 days, I call him today, the patient is asymptomatic. The second patient is a very interesting one. He's a 4-year-old male, 4 months post-transplantation, was transplanted from an aggressive form of wild-type amyloidosis cardiomyopathy. He had renal failure after transplantation and other problems, but he recovered all his complications quite well. He's in cyclosporin and mTOR inhibitors. When we decided to discharge him to a dialysis out clinic, for this reason we tested him and it was positive. So at this time he was completely asymptomatic. And our strategy in this case was just to wait and see. So I think the key message of this slide, we think that it's possible to have a very mild form of COVID-19, also in transplant patients, but we believe maybe that this is the exception that proves the rule. So next slide, please. Now let's speak about our inpatients experience. The first patient is a male, 66 years old, 3 months post-op. He was transplanted after 25 days of ECMO, so he had a lot of complications, but he recovered quite well. He was in cyclosporin and mTOR inhibitors. We tested him before discharging him to rehabilitations, and it was positive. So the day after the test, he started to have fever, cough, and the oxygen saturation was slightly reduced. So our strategy in this case was to stop everolimus, and we treated him according to our hospital protocol that at this time was an antiviral agent, Keltra, azithromycin, hydroxychloroquine. But to be honest, now we have stopped Keltra because it's a nightmare also with interaction with cyclosporin. We didn't notice any benefits. So the patient now is stable but still in oxygen max. The second patient is a female patient, 4 years post-transplantation. She was on cyclosporin mycophenolate. He started to have fever and dry cough, and after 5 days, he had developing worse symptoms. So for this reason, he was admitted to the hospital with respiratory distress. She was positive. Again, we tested him for COVID-19 infection. So in this case, our strategy was to stop mycophenolate. We start our hospital protocol, and she requires CPAP treatment, but now she's in really critical conditions. So the key message of these slides, I think, is that in COVID-19 is a very aggressive in immunosuppressive patients, and the patient could deteriorate very easy. So it could be reasonable to reduce as much as you can immunosuppressive treatment. So next slide, please. Okay. Finally, the last 2 patients, the one which we have lost. The first one is a male patient, 5 years post-transplantation, 6 years old. He was in azathioprine and cyclosporin. The first symptoms were fever and cough, but he came to the hospital late, after 7 days. in very critical conditions. The saturation was very low, and we lost him after 10 days. The second case that is quite interesting because it was a lovely lady of 74 years old, 29 years after transplantations. He was on cyclosporin, everolimus, and mycophenolate. He was admitted before COVID-19 outbreak in our hospital on 15th of January for a severe episode of heart failure due to antibody-mediated rejection. So we treated her with 4 cycles of plasmapheresis, rituximab, and she developed COVID-19 infection after the second dose of rituximab. And unfortunately, she died after 5 days. So I think the key message in this case is that if you have an outbreak of COVID-19 in your hospital, think twice before to treat any patient with high immunosuppressive regime. And thank you for your attention.
Yes, okay. Good afternoon to everybody, and thank you for the opportunity to share with you this couple of slides. So if I may have the next slide. So my task is to briefly speak about what are the treatment options that we currently have, and the first statement, and that there is no approved drug for the treatment of patients with COVID-19, either for the general population and particularly for the solid organ transplant population. And the clinical management includes infection prevention and control, and supportive care, including supplementary oxygen, non-invasive ventilation, and mechanical ventilator support when indicated. So in my unit, I have 30 beds. They are all with COVID-19 patients. Hopefully, none of them are transplant recipients, but 50% of them are on CPAP or non-invasive ventilation because of severe interstitial pneumonia. And what we started doing was using, based on the Chinese experience, lopinavir, ritonavir, Calitra, but then the Calitra is not any longer available in Italy, so we switched to darunavir, ritonavir, or darunavir cobicistat as an alternative. And but there are no data to support this. This was just because we didn't have an alternative, and all these antiretroviral are used in combination with chloroquine that we don't have in Italy. We use hydroxychloroquine. And but recently, the data that have been published last Thursday on the New England Journal of Medicine from an underpowered trial have shown limited efficacy of lopinavir ritonavir, at least in the most severe patients. Apparently, there is some benefit if you start very early, but not very much when the disease is already there. And remdesivir is an investigational intravenous drug that inhibits the viral replication through premature termination of RNA transcription, and has in vitro activity against SARS-CoV-2, has been developed for Ebola, but then has been shown to be in vitro active against this new agent. And there are currently several ongoing randomized controlled trials that aim to examine the efficacy and safety of intravenous remdesivir for COVID-19, so 200 milligram and then 100 milligram per day IV. Next slide. And this is just a slide showing the figure of the improvement rate of patients treated with severe COVID-19 treated with lopinavir ritonavir compared to control. And as you can see, there is actually no difference. So the conclusion of this trial, that there's some intrinsic limitation, are that this approach is not so effective as we were hoping at the beginning of this terrible epidemics. Next slide. And there is accumulating evidence that suggests that a subgroup of patients with severe COVID-19 might have a cytokine storm syndrome, and tocilizumab is a recombinant humanized anti-human monoclonal antibody directed against the soluble and membrane-bound interleukin-6 receptor, and the drug as an intravenous and subcutaneous formulation. And from my preliminary experience in non-transplant recipients, because the drug, at least in Italy, but also in Spain, is not allowed to be used in patients with immunosuppression, including solid organ transplant recipients. I don't know if this will be different in the US or in other countries. But the preliminary results, so I treated yesterday 2 patients who were on a non-invasive ventilation from a week with a very slow recovery or non-recovery, and today they went off the non-invasive ventilation, and they are just with some oxygen supplementation. So it's just anecdotal, but in some cases with severe hyperinflammation, it seems to be really effective. The convalescent plasma that has been used in China is currently not recommended. There is the Survival and Sepsis Campaign guidelines that have been just published a couple of days ago, and this is a statement that I've taken from that guide, that is not recommended in treating patients with COVID-19 until more evidence is available. And there are many vaccines under development, but none is currently available, and I think that it will take months before we will have something that we can use for preventing this infection in the general population and the solid organ transplant population. If I can go to my last slide, just to remind that particularly the PI, the protease inhibitor, the antiretrovirals, have major drug-drug interaction with many immunosuppressive agents. So the recommendation is to be very careful if you are going to use this drug in the solid organ transplant population, because you may run into overexposure of immunosuppression. Thank you very much for your attention.
If you go to the next slide and just hit enter 4 times, one more after that. Thank you. This was the problem of doing the slides at home. At any rate, I thank you for allowing me to talk a little bit about community and hospital preventive strategies, which I know many of us know already, but perhaps need to be emphasized again. Washing our hands, while it sounds simple, is really the mainstay of preventing transmission, and proper hand hygiene of 20 seconds with soap and water or alcohol sanitizer after touching any item that has been touched by other individuals before touching one's face, nose, or eyes is critical. It's important to avoid secretions of other people, and as the picture of the classic sneeze studies show, we really do need to maintain a distance of 2 meters or 6 feet. As a pediatrician, I always felt that teaching children hand hygiene and proper cough and sneeze etiquette was perhaps the most difficult, but as I have been observing my colleagues and my friends, I recognize that it is perhaps harder to educate older individuals who their entire life have been coughing and sneezing into their own hands. So I really feel like it needs to be emphasized again and again. To cough or sneeze into a tissue and throw it away, not put it in your pocket, or to cough into the crook of your arm if there is not one available. Self-quarantining is really important for our families and for our healthcare workers as soon as we get sick, rather than trying to simply power through, as we can be the transmitters to others, as perhaps shown on the slide that Dr. Ajit Lemay showed earlier, with 2 of their patients had acquired their infection while in the hospital institution. If there are symptoms, they should even try to be quarantined from their families, eating in their own bedrooms, using a separate bathroom if available, and cleaning and disinfecting the areas that have shared areas. Societal quarantining with staying at home as much as possible is quite important, particularly for our transplant patients, and decreasing the number of people with whom our transplant patients interact. And does it work? Well, the early data that came out of the Wuhan district of China suggests that it may or does. Dr. Zhongli Ren and colleagues showed a low incidence, much lower than what would have been anticipated for their 87 heart transplant recipients in the descriptive survey that comes out today from the Journal of Heart-Lung Transplantation, showing that the majority of their patients did practice enhanced precautions of self-quarantining, and that this may have impacted the decrease in disease transmission to them. If we could go to the next slide. Preventive strategies within the hospital, and again, if you could hit it 3-4 more times. I think even once more or twice more. Fabulous, thank you. So sick patients, if you should be instructed to call the institution before they are coming in so that we can know that they are coming pre-arrival, assess them and mask them quickly and isolate them. For proven patients or those that are persons of interest, negative pressure rooms, if available, and neutral rooms, if not available, are important. Again, limitation of people going into the rooms of proven cases or persons of interest. Personal protective equipment is critical, having mask, gown, gloves, and eye protection. And of course, we are finding all too frequently that we are running into shortages with this. In those institutions that have the capability, even having an observer to watch people putting on their personal protective equipment so that it is shown to be appropriately done is helpful. Saving the fitted respirator mask for aerosol generating procedures and not throwing them away, but having protocols and policies available for how to reuse for those individual patients. Cohorting patients is going to have to vary by institutional variability in your access to rooms, but trying to have them away from the transplant patients that are not infected is important, and will be discussed in more detail by Dr. Humar later on. And again, hand washing frequently. The concept of should our patients be coming to appointments, I think, has to be taken by case. One should think about whether or not this is just a screening appointment or one where there is a concern for them having rejection. Consider masking them when they get into the hospital, even if they are not sick, and having them ushered into a room to avoid touching areas that may have been touched by other people. Using teleconferencing will again be discussed later in this town hall, but is something that each institution should look into to not have patients come unnecessarily into the institution where they may come in contact with infection. And again, hand washing frequently, and I will stop there. Thank you very much.
Go to the next slide. Fortunately, we have some data from pediatrics, although it is quite limited. The majority of this data has come from China, and initially indicated that less than 1% of the cases which were presenting to the hospitals were in children younger than 10 years of age. I think it's important to note that this information on this slide represents information in hospitalized children, both in Wuhan and the surrounding provinces, where the proportion of patients who were positive for SARS-CoV-2 ranged between 1.6 and 12.3%. The ages ranged from 1 day up to 15 years, and the majority of patients had fever. The patients who became critically ill, all at one institution at Wuhan's Children's Hospital, all had significant comorbidities. And to date in that population, there was only one death reported in a 10-month-old that had a comorbid condition with complicated intussusception. Neither of these institutions reported any transplant patients among those who were positive. Next slide. Since those initial reports, there's been a large report published last week in the journal Pediatrics of 2143 children who had COVID-19. 34.1% of them were laboratory confirmed, and the rest were presumed based on epidemiology. Again, the median age of these children was 7, and most interestingly, younger children and infants were more likely to have severe disease, with up to 10% of children under the age of 1 year having severe disease reported, and only 3% of those 16 and over with severe disease. Again, no transplant patients have been noted in this cohort either. I think it's also important to remember in this population that we're seeing increasing reports, both from China as well from other regions, that pediatric patients may be more likely to be co-infected with other respiratory viral infections, and that the presence of influenza, human metapneumovirus, RSV, or parainfluenza virus does not exclude necessarily a patient from being co-infected with SARS-CoV. Fortunately, to date, though, pediatric patients have fared much better than adult patients, although we need to be vigilant, and we are looking for people to actively report their patients should they become positive. Thank you.
Hi, it's Dipali. Can you hear me now?
We can, Dipali. Thank you.
Okay, perfect. Okay. So I just want to go back to when we were talking about the infected transplant recipients, and this is a question for Ajit. Ajit, do you have any general idea of whether the patients that we're seeing the transplant patients we're seeing have more severe disease than, let's say, non-transplant patients? From the patients that you described and that you've heard of?
Yeah, again, our experience, as I pointed out, is very, very limited, and I'm very interested to hear what our Italian colleagues are describing, which again is very different than our very initial experience with just 5 patients. Some of the limiting factors, I think, that may go into the picture that I presented with the 5 cases that were summarized are that they were all patients who were distant, means a median of 15 years after transplant on low-dose immunosuppression. And despite having significant comorbidities, so far, with very limited follow-up, the patients have generally done well. And it at least raises the possibility, based on what appears to be emerging from pathogenesis work, that perhaps the host response is as important as the virus in determining the course of disease. So could it be that despite having multiple risk factors for progressing or having very severe disease, that the very low-dose maintenance immunosuppression that these patients were on in some way might have modulated the expression of disease? Highly speculative at this point, but I was surprised, based on that, again, very limited experience, that none of the patients with 7 days of follow-up, to be clear, have progressed to requiring intubation or progressed to death, as has been described in many people with those same comorbidities who are not necessarily receiving immunosuppression. But that's a fundamentally important aspect of for all of us in transplant.
Mm-hmm. I guess the other issue is that I wonder if we are missing patients that have atypical symptoms that maybe are not even getting tested. I don't know if you've had any insight into that.
I think in part our experience has reflected the availability of rapid real-time testing as one of the first centers in the U.S. to have that go live. And we are finding a much broader range of illness, perhaps, than was initially recognized and described in China. And so one possible explanation for our findings of, quote, relatively mild disease is perhaps related to a testing bias, that our prospective testing recommendations and guidance that we've developed that are open for everyone to see through the UW COVID website are to test all immunosuppressed patients, solid organ transplant patients who meet any of the criteria in terms of symptoms. So perhaps that has led to identification of patients who in other locales might never have been tested. So I think the indications for testing is probably going to turn out to be an important determinant of the expression or the recognized expression of COVID-19 in SOT.
Great, thanks, Ajit. Question for Paolo. Paolo, there's been a lot of talk on using hydroxychloroquine for treatment, for post-exposure prophylaxis, and for primary prophylaxis right after transplant. I'm wondering if you can comment on the side effects of hydroxychloroquine and what we need to do in terms of monitoring the patient for adverse effects.
So, thank you for your question. So, I don't think there is any evidence that chloroquine or hydroxychloroquine can be of any benefit as prophylaxis. So, there is a lot of attention, and many people are using this approach, not just in transplant, but also in the general population. Many physicians in the emergency room are trying to use, but I just admitted a patient with a severe interstitial pneumonia due to SARS coronavirus 2, who was on chloroquine treatment from long time because of a rheumatologic disease. So I'm not sure that is, I mean, it's just one case, so it's anecdotal, but I'm not sure that this is going to be of any benefit. And we are short of hydroxychloroquine, that is the only drug available in Italy, and we are using probably inappropriately. So I'm not sure that this is something that we should do. And in terms of side effects, so we should be careful for what is the potential QT prolongation related to chloroquine or hydroxychloroquine administration. So I'm not really convinced that this is the way to go to give everybody this drug. So there is a shortage of the drug, and in my personal experience, it didn't work at all as prophylactic agent to prevent severe coronavirus disease. So that's my personal point of view based on a limited experience, but I would like to see some strong data to support this before using universally in all recipients as prophylaxis.
Great, thanks, Paolo. I think, you know, I'm glad you highlighted that, you know, this hydroxychloroquine is, the supply may be limited, and also, you know, we really don't have a lot of evidence of using it in infection or for prophylaxis. Just one last question for Attilio, if you're still on the line. You talked about immunosuppression withdrawal. Has there ever been any thought about actually giving steroid bolus to patients who have severe pneumonitis in terms of reducing the inflammatory response? It's sort of difficult to know what to do, if we should try to reduce the inflammatory response versus withdraw immunosuppression to combat the virus. Just wanted to get your thoughts on that, Attilio.
Well, can you hear me?
Yes, we can,
Yes.
Attilio.
Okay, so our experience with steroids, we have tried in very advanced patients, and we didn't notice any substantial benefits. But in mild form and maybe in moderate form, we have used steroids to reduce the other dose of, for example, cyclosporin or tacrolimus, and we didn't notice any episode of rejections. So our standard protocol now is to use steroid in the mild form, at least, and reduce as much as you can the immunosuppressive therapy. But of course, we don't have any evidence. And on the other hand, when you treat advanced patients, I think it's always, you have a lot of bias So it's difficult to understand if steroids is really appropriate.
Thank you. Okay, so in the interest of time, I think I just want to say thank you to all of you, and I think we can move on to the next section.